That is the horizon that we have reached, but we want to go beyond that horizon. It means that as we are speaking now, still there's women and children dying. So we should not be complacent with the numbers that we have now. The causes of maternal and newborn deaths are known, as we have already mentioned the previous sessions. We know that women die because of hemorrhage, women die because of eclampsia, women die because of sepsis. We know all those things. But we know also that we can prevent such deaths. There are scientifically proven methods of preventing, for example, postpartum hemorrhage. We have interventions like active management of the third stage of labor. We have magnesium sulfate for managing eclampsia, but still women are dying because of hemorrhage and eclampsia and such things, despite having all the means of preventing these deaths. So what is missing? There must be something that is missing. That is why we still see a lot of those deaths. So today's agenda is about looking at going into depth, looking at what is happening. Why should we have those deaths despite all the facilities, all the resources that we have at our hands, and we still cannot prevent those deaths? So we should go behind. We should go beyond where we have reached the 104 per 100,000 live births and 25 per 1,000 live births. The time of the SDGs is drawing very near. We have a very short time to SDGs. 2030 is just around the corner. So we need to have concerted efforts in order to reduce maternal and newborn mortality. And the way to go is to find the root cause, analyze the root causes, and find the ways to cut the roots. Tukate mzizi wa fitna wanasema. So we have to look at the root cause analysis and cut it so that we can get to the targets come 2030. So our session, we are going to have a 1.5 hour session today, and we have divided it into 2 parts. The first part will be panel discussion that I will moderate. The second part will be about forging a way forward. My co-moderator will moderate that one. And so, without much ado, let me introduce the keynote speaker. We are going to have a keynote address by our director from the Ministry of Health, Department of Reproductive Maternal Child Health, Dr. Makwani. He's going to be our keynote address speaker. Dr. Makwani has been attending various sessions since day one of these meetings. But for those who don't know Dr. Makwani, as I've said, he's the director of the Department of Reproductive Maternal and Child Health, the Ministry of Health. He's a senior obstetrician gynecologist consultant with an extensive experience spanning over 25 years. He's an expert in reproductive maternal, newborn, child, adolescent health policies and service delivery and surveillances. He has also led initiatives to reduce maternal mortality, as I have said in the beginning of my talk. And he has developed several guidelines and teaching and training manuals in RAMCA. He holds a degree from the University of Dar es Salaam. That the first degree, he did it when it was called MUX. It's not MUHAS. Yeah. This long time ago. Muhimbili University College of Health Sciences. So he graduated his first degree there, but he also holds a second degree in obstetrics and gynecology from the same college. He has a lot of experience in RAMCA services and trainings. So I'll take this opportunity to welcome Dr. Makwani to deliver the keynote address. Tumpigie makofi Dr. Makwani pasa. Karibu sana mkurugenzi.
Good morning. Habari za asubuhi. Our task today is to go through a report that underlines what we have done in terms of looking at the causes of maternal death and newborn death. And this is a process of root cause analysis. So when we say root cause analysis, what does it mean? Root cause analysis is a process of looking various operators of a problem, finding the driving forces, but also trying to come out with a way for remedy, or in short we say a response to those shortcomings. This was one of the interventions that we used in the entire process for addressing the causes of maternal mortality and child mortality, so that we can find those drivers, deal with them, and at the end of the day contribute towards improvement of service delivery, but also in turn to attain the intended outcome, which is survival, in line with the RAMCA Strategic Plan 2016-2030, which calls us to attain 3 goals. The first one is survival, the second one is thrive, but the third is transformation. So in this case, we are talking about survival. Now, through this root cause analysis, we have done root cause analysis in institutional, meaning the facilities. We've done root cause analysis as per region, for example in Dodoma, Dar es Salaam, Mwanza, institutions such as Muhimbili, Bugando. And when you look at those root cause analysis, you will find that most of the challenges are within ourselves, that if we deal with them, we will ensure what is called survival. And for all of us, we know that we are striving to reach the goal of reducing maternal mortality below 70 per 100,000 live births by 2030, reducing the neonatal mortality below 12 per 1,000 live births by 2030. But if we don't know the facts which lead to this death, it will be a dream for us to reach those goals. Let me say there is a huge change of pattern of causes of death currently. If we were to do this root cause analysis in years such as 90, 2000, possibly things like human resource, issues like no supplies, issues like no health facilities would be very prevalent. Currently, that picture has changed, and you are going to hear a lot from the speakers here. So, without much ado, I would like to take this opportunity to thank the speakers to agree to convene today but also to thank you from different corners of Tanzania and outside Tanzania to come and listen on these issues from the root cause analysis. Possibly this explains one of the calls, global calls, saying that Tanzania, you need to share your experience. You need to share ways you used to reduce maternal mortality. And to be sincere, we had no mercy at all in terms of addressing causes of maternal mortality. We galvanized to the routine review of maternal death and neonatal death, but also we innovated. We put in place the Zoom reviews, which most people don't like it. Recently, I was reviewing some of the interviews from the community in Singida and Mtwara. One of the comments which came out from there, they are saying, you know, meet with the experts from all over Tanzania. And those experts, they will ask one question several times until they get the reasons why it happened. And it is a very painful process. We introduced this one by using the so-called addressing the issue of comfort zone. Most of us, we don't want to be shaken in our positions. We want to keep our status quo. So we want, when we do these reviews, to tell why you didn't do A, B, C, D at a point. And I'll use our colleagues from Uganda, the experience of our colleagues from Uganda. They say, you use a gentle pressure, just gentle pressure, to get the facts. It has worked, it has changed. It started with a Zoom review at the national level. Currently, the Zoom reviews are in sub-nation. So I would say it has been accepted. Although there is a mixed feeling among health workers, some of them, they don't want even going to work in the labor room, but at least people, they have a time whereby they think there is somebody, there is a peer review that may come in. So, ladies and gentlemen, without much ado, I would like to go back to the moderator so that he can call the various contributors, and then we can hear and what has happened, what information they got from the root cause analysis. I submit to you. Welcome to the session.
Thank you, Dr. Makwani, our Director at the Department of Reproductive, Maternal and Child. Let us put our hands together for Dr. Makwani again. Yeah, thank you very much, Dr. Makwani, for those words. So it will be a why until you get to the root of the problem. Having said that, and without losing much of your precious time, we'll have three speakers in the panel, and Dr. Njoge will not be a speaker, but he will moderate the next session. As I've said, this session has two parts. One is a panel discussion, the other one will be to forge a way forward from the discussion. So I'll introduce Dr. Njoge when his time has come. But let me take this opportunity to introduce the first panelist who will be coming forward to take his seat, and it is none other than Dr. Sande Dominico. Dr. Sande Dominico is a consultant obstetrician gynecologist with an experience of almost 14 years. Dr. Sande has experience in clinical care, experience in training, and experience in policy development and the program management, all those focusing on reproductive, maternal, and adolescent health. Currently, he is the president-elect of Agota, and he's a national MPDCR focal person at the Ministry of Health, and he's also a director of programs at Thamini High, and he has co-authored almost 15 publications, and he has a lot of efforts that he has made in contribution to reduction of maternal and newborn mortality in Tanzania. Welcome, Dr. Sande, to take your seat. Please take your hands together for Dr. Sande. Karibu sana, Dr. Sande. Another panelist is Dr. Lipingu. Dr. Lipingu is also an obstetrician gynecologist with over 20 years experience in providing technical assistance. Currently, he is serving as a senior technical advisor at Japaigo in Tanzania. He has contributed a lot in the development of the guidelines and training packages in emergency obstetric and newborn care. The package also includes MPDSCR guidelines and CMOC and BMOC guidelines and training packages too. He has led root cause analyses for maternal and perinatal outcomes across various regions in Tanzania, mainland, and in Zanzibar. So, Dr. Lipingu, please take your seat. Please put your hands together for Dr. Lipingu. The third one is Dr. Godlisten Martin. Dr. Godlisten Martin is a medical doctor and a public health specialist with over 10 years of experience in his field, especially in maternal and newborn care. He has experience working with local and international organizations which are addressing the burden of maternal and newborn mortality and morbidity. Currently, he's working with Japaigo in a USAID-funded project that is USAID Afya Yangu Mama na Mtoto. And he's an advisor who has been supporting the regions, 10 regions in the mainland and Zanzibar, in a primary and secondary and tertiary health facilities. He has pioneered in the use of data for decision-making around the area of maternal and newborn health and maternal and newborn death. Please, Dr. Godlisten. Yeah, can you put your hand together for all of our panelists, please? Yeah, so we are going to ask ourselves that why do these maternal and newborn deaths occur, despite of all the interventions, despite of all the resources that we have, but we still have the maternal and newborn death. As we are speaking now, women are still dying. They haven't stopped dying. Women are dying, newborns are dying. So we know that there's something that we should do to prevent these deaths or stop them all together. So let us first hear from Dr. Sande. Dr. Sande, maternal perinatal death surveillance, that is MPDCR. This one has been invested and prioritized in Tanzania as one of the high-impact interventions to foster accountability and improvement in quality of care along the continuum of care. MPDCR data is also essential in understanding the root cause of maternal and newborn deaths. Now, can you please describe the MPDCR process at the national level and what are the major milestones that have been achieved up to date? So please, Dr. Sande, you have this opportunity to discuss the audience as to the national level issues on MPDCR and the achievements, including the data. Karibu sana, Dr. Sande.
Thank you, moderator, Dr. Mzee. Ladies and gentlemen, the audience, for those who are there before the Kagera Wash, Kamoni, the rest, mambo vipi. So it's an honor and a privilege to be here in this forum, discussing a very important subject, but a subject very close to my heart as a national MPDCR focal. We understand our nation is at war and trying to do the very best to reach the Sustainable Development Goals. And the keynote speaker highlighted the SDG number 3, and that requires us in the next 6 years, to be able to cut down the maternal mortality to less than 70, under 5 to less than 25, and neonatal mortality to less than 12. And we take note that the country has really taken this challenge at various levels. Our national constitution, we have the National Development Agenda and the Tanzania Development Vision, but also the Sector Strategic Plan and One Plan 3, all of those highly prioritizing reduction of maternal and perinatal mortality. And we are aware that currently we're in the jubilant mode, because things are like they are coming. Our maternal mortality over the previous 1 decade has declined over 80%, under 5 mortality over 34%. We know that we still have challenges, only 4% reduction in the previous 7 years. Now, if you look at the horizon, the next 6 years, you don't rest as a nation. You really have to dig down and see how much you do more, extra. We're talking about the extra initiative. We have done a lot. How much do you do to ensure that you accelerate initiatives? And to be able to do that, you have to be guided by evidence. So WHO has a number of interventions which have been recommended, and one of them is MPDCR. And it's not by chance or choice. The Cochrane database review that came out 4 years ago has shown that if you implement MPDCR very effectively and link it to the quality improvement initiatives, it's likely to cut down maternal mortality by 35%. You talk about 35%, perinatal mortality by 30%. Now, what lives behind this important intervention? So, when WHO brought forward the 3 publication Beyond the Numbers, that was almost 20 years ago, that every single maternal and perinatal death has to be reviewed to be able to draft clear public health actions to reduce further death. Tanzania was one of the very first adapters. In 2006, we started working on this process. We had another guideline in 2014, and the latest guideline of 2019, which will guide the MPDCR process to be able to bring the intended change. And for those who are in this room, maybe you are hearing MPDCR for the first time, it's really an institutional process where you look at how much you would be able to use the information you learn from the occurring maternal and perinatal death to be able to respond aggressively, timely, and quite laser sharp focus. And in this way, to be able to make you understand better, MPDCR actually is 4 words, and in those 4 words, the first of course is maternal, perinatal, and then you have surveillance and a response. So you talk about a surveillance. When it comes to maternal and perinatal death, you talk about a continuous process across all the service delivery points and the community, trying to identify which death is happening that are attributed to the pregnancy, puerperium, and the complication of pregnancy and childbirth. Identify those deaths and then notify to the relevant channel, and that's what we call surveillance. Now, this is a very well done process in most parts of the world. Now, the second part, which is key and crucial, which of course we reinforced in our previous guideline, is how much now you convert this information into the right recommendation through very extensive reviews, and then develop action plans to be able to respond to the issues. And this part of the response, together with the review part, that's what we call the R part, or the response part of the MPDCR. And these processes, they are really continuous. You have to go do them continuously every time you take care of the issues. So in our country, this has been happening for years. Now, what makes the difference between now and the previous times? We have real intensified our approaches. The keynote speakers made my work very easy, just to put deep insight on some of the issues. We understand there's been an MPDCR process where I will call it, for you to be able to understand, call it a sort of a prototype or traditional MPDCR, where we have committees at all levels, and these are guided by the guidelines. And in those committees, which are prescribed, who sits on specific committees, reviews are done, and then recommendations taken on paper, actions done, and the like happen. So 3 years ago, we learned that this process has really taken us at a point, but we need to do more. And it's when we learned that, yes, there are some issues on the quality of reviews, especially identifying the correct causes as per ICD classification of the maternal perinatal death, but also we had some issues on the identifying the actual dysfunction. But the major problems were in the way the teams were accountable to respond to the issues. Give you an example. You have a pregnant mother who went to the clinic maybe 2 or 3 visits, and then she came to a facility, and then as a result of that, she gets a postpartum hemorrhage and dies of shock because of postpartum hemorrhage. In the previous reviews, someone would come forward and say, this lady died because she made only 2 visits. So you ask yourself, if she had made 7, 10, 20 visits, will that prevent shock and make her survive and see the tomorrow and take care of the baby and the family? So after learning this, now we brought in other innovative methods. My boss talked about the virtual reviews. I'll talk into that a detail further, which has really opened our eyes on what we see on the pattern and the trends of maternal mortality. But also, we went into the root cause analysis. And this actually started over 5 years ago. We are sharing today, but we have been doing for over 5 years. But we intensified our effort this year because we really wanted to see what else can we do to reduce the remaining burden of maternal perinatal mortality. And in the root cause analysis, you have teams of experts that go to specifically targeted regions or facility which we have observed unexpected burden and trend of maternal mortality. Dig deep, arrive with the issues how to respond. But also this year, we are working with a team. I'm very humbled to lead a team that is developing a national confidential inquiry report that we'll be able to bring to you. And they won't take that report to be able to hit hard at the high level. You know, maternal mortality is a complex, multifactorial phenomena. You do things in the labor ward, you do at a managerial level, but things have to happen at the highest possible office in terms of the advocacy. So we are working on a confidential inquiry report as another approach to be able to bring everyone, open the eyes, and get the right necessary action to accelerate our efforts. Now, when it comes to the virtual reviews, when I talk about this, I'm always very happy and jubilant, because when we started this, it was something that you could easily continue doing. But everyone was having different thoughts, minds, whether this one is going to make us see things in a different angle. So the virtual reviews will start in 2021. It's almost 3 years now. And over the course of the implementation, we are learning and improving the processes. And as of by April 2022, the reviews, February, the reviews, Assistant Director, me and some few other experts, including Dr. Lipingu, but we formed a steering committee. And in this, let me thank the professional associations, AGOTA, and you clap the hands for them, please. AGOTA, TAMA, SATA. These were critical to ensure that we really work together in this very difficult journey. So we formed a national steering committee in which you have everyone on duty to share specific, to chair specific sessions. In the course of process of reviews, we also developed a national coordination committee, but also incorporated the P aspect, the perinatal reviews that we did last year in April. And as a result of this process, we have been able to sit over 500 meetings in the course of 2.5 years. In that process, we'll be able to review over 700 maternal deaths, but also reviewing perinatal. Those are remarkable numbers.
considering that we're in a very wide, huge country, quite spread with a lot of issues. But this is not the story that I want to tell you. The story is the virtual reviews have really changed the way we look at the systems in terms of improving the maternal and the perinatal landscape in the country. And the major issues is we have always been asking ourselves, what causes maternal and the perinatal mortality? You go to a manager at the regional council level, they'll tell you because we don't have equipment, we don't have supplies, because the women are coming late to the clinic, they are making fewer visits. But competence in managing obstetric complication, PPH, preeclampsia, eclampsia, sepsis, issues on how to manage perinatal complications, birth asphyxia, prematurity, and the like. And this one, I tell you, is a groundbreaking innovation because today, everyone knows that we have to address competence of the healthcare provider. The minister knows it, the deputy minister knows, the permanent secretary, and everyone. And we have designed a lot of intervention to respond. For those who have been going into the MOH forum, you have heard of Mama Samia mentorship program. This is one of the responses that came out after learning from this. But we also intensified our efforts to review, develop a lot of guidelines. Because of the limited time, moderator, I want to be able to go into everything. But what I want to tell you is, if you really have a very well structured MPDCR process, it's likely to avert scores of maternal and perinatal death. And because today we are talking about the root cause analysis, let's deep dive into that, and you get to learn more what you have been learned from the process in the past 1 year. Asante sana, moderator.
Thank you very much, Dr. Sunday, for that opening. So that the higher level, the Minister of Health level, the response part has been strengthened. We have established national steering committees for MPDCR. We have engaged the professional organizations, and we are also addressing the competencies of healthcare workers. Thank you very much. Put your hands together for Dr. Sunday again. Sante sana, Dr. Sunday. That is very good. So let us go to the second. Please keep your questions and discussions. We shall have a time for that. Now, Dr. Lipingu, we have heard that the national level, there are a lot of achievements in addressing maternal and perinatal death through institutionalization and capacity building at health facilities to use the MPDCR processes Dr. Sunday has mentioned. We know that MPDCR is essential in documenting the causes of maternal and perinatal death that have proven to be effective in identification of the level where it has occurred. Now, we know that USAID Afya Yangu Mama na Mtoto has been using MPDCR data to support the Ministry of Health to conduct root cause analysis in specific regions in mainland Tanzania and also in Zanzibar. Now, can you please describe the root cause methodology and coverage of this approach which the Ministry of Health has been supporting? Karibu sana Dr. Lipingu. Asante sana. Can you pass the speaker, please?
Good morning, everyone. Thank you, moderator, for inviting me to this discussion. And I'm very happy to be in this forum because I've been working in maternal health for many years, and I participated in development of many materials, including MPDCR. JAPAG has got many projects, and we started supporting the Ministry of Health for all the MPDCR guidelines that are existing. And in 2019, we did, in 2017, we did analysis of existing guidelines of MPDCR. And we found probably we had to review, and that's why we have another guideline of 2019. So with all the process that has been explained by Dr. Sunday, we found that there's a need of going deeper to the root cause. And the root cause, that means you go down to the regional, council, and the facility level. So the team of experts was formed by the ministry, and they went to Dar es Salaam, especially Muhimbili, Mwanza, and Tabora. And these regions were selected because they have contributed to a lot of maternal mortality. For example, Muhimbili, Dar es Salaam in 2023, there was almost more than 200 maternal mortality. And in Mwanza, it was more than 144 maternal mortality. And even Tabora. Now in Dar es Salaam, despite the fact that almost 200 maternal mortality, but Muhimbili almost contribute to more than 50% of maternal mortality. That's why we had to go to these regions, and especially Muhimbili, to see what is the existing. And different from other approaches, this approach goes down to reviewing the real files. So the team of experts of maternal health, like obstetrician, gynecologist, anesthesiologist, experienced midwives, they go to the region and pull all the files and critically analyze what is existing. So there were some objectives. Of course, the team had a TOR, and we had some objectives. The first one was to determine demographic information, whether they impact the maternal mortality. The second one, to identify the delay in decision making and care, which contribute to the maternal mortality. And also they examine the quality of care during pregnancy, labor and delivery, and immediate postpartum, whether it can contribute to maternal mortality. And also to check the contributing factors and do recommendations. So the team of experts, they pull all the files in the regions, and we had a framework of examining the case through all the steps, from admissions. If the patient was admitted in a certain area, what time was she admitted, what care was she receiving, and if there was a referral, whether she was receiving pre-referral management, and whether it's correct or not, and what's the time of referral. If she was received at the higher level, what time was she receiving and the day, and who received the patient, and what care was she receiving. And then we examine the quality of care and check the factors. And therefore, we enter this in the certain tool. Previously, when we did it for the first time, in 2019 in Muhimbili, we used the normal Excel sheet. But that is very cumbersome in terms of analysis of the data. So currently we have a tool which is called Kobo Toolbox, which is electronic and online. And therefore, if somebody enters the data, everybody can see what is in that data and can be analyzed very easily by Starter 17. So this is what, in short, we have done, and probably from the result, then you can discuss more. Thank you so much.
Thank you very much, Dr. Lipingu. Please let us give Dr. Lipingu 3 claps. Asante sana for that address. Now for Dr. Martin. Dr. Martin, good listen, Martin. Given the audience now understands the methodology and the scope of root cause analysis, as was described by Dr. Lipingu, now can you please describe the major findings and how the project has used these findings to target and support the interventions as has been mentioned by Dr. Sand. Karibu sana, Dr. Martin.
Okay, thank you. Good morning, everyone. For result, the results were divided in 2 parts, and the first one was qualitative, and the second was quantitative. The qualitative data or the information was based on MPDCR process. We interviewed the MPDCR committee team members at the regional level, district level, and at the facility level to know how they are processing the MPDCR at their levels. So the findings from discussion, we found that at the regional level, the MPDCR process have been conducted regularly, and the process of doing the MPDCR at the regional level is following the standards, because they are reviewing the previous action plan, they are reviewing the implementation, but also they are reviewing the cases and develop the action plan. But at the district level, we found that the review at the district level, all the meetings were not done according to standard because some of the districts were not conducting the MPDCR meetings, and the quality of those meetings were rather RMNCH performance indicator meetings compared to the MPDCR process because they were not reviewing the maternal and perinatal death, they were reviewing the performance of indicators. And the reason for not doing the MPDCR at the district level was the reason were economic issues. They said they are not having the budget to conduct the meetings at the district level. At the facility level, the meetings were being conducted, but mainly after maternal perinatal death. And when the perinatal death are occurring at the facility, they are not doing it regularly. They accumulate them at least maybe 2 or 3, and then they are doing the MPDCR meeting. So the meetings were not done according to standard, which is weekly. And the quality of review were not standard because the review sometimes come up with the findings which are not implementable or does not address the main gaps. So what the project did at the regional level, we continue to advocate to continue the meeting, but also we continue to support the meeting at the regional level. And at the facility level, we continue to make sure that we participate in those meetings to capacitate them on how to conduct the meeting properly. And at the facility level, we continue to participate in the review and also supporting the expert reviews at the facility. We work very, very closely with the professional association to make sure that we use them to support the facility to review the cases. But also we conducted the training on MPDCR. On qualitative findings, we looked at, Dr. Liping said, across the continuum of care from when the patient was at home, when on the way to facility and at the facility. So we used the 3 delay models. So when we looked at the ANC, we started to look the direct link between ANC and the death, and we found that almost 20 to 30% of all maternal deaths were related direct to ANC suboptimal quality of care. And the gaps which we observed there, the healthcare providers were delayed to detect the complication, particularly the severe preeclampsia, eclampsia, but also when they have detected the risk, for example, 2 previous SCAR, they are not doing the proper referral to targeted facility. So what project did, we worked very closely with the government to make sure that we conduct training at the facility level on ANC to make sure that we capacitate the healthcare providers, but also worked with the community health workers to make sure that we link the issue at the community and the facility. But we are now working with the regions to use the electronic tracking tools, and these tools will be able to track the risky pregnancy at the facility and link them at the community so that we can able to track the risky pregnancy at the facility. Also, we looked at the mode of deliveries. We observed that almost 50% of all deaths were from cesarean section, despite in having only 20% of all deliveries in those regions, but it contributed to 50% of all maternal death. And this is because of suboptimal quality of care during the gap in doing cesarean section. So the complication which arises from that procedures contributed to maternal death. So the project, what it did is to make sure that we capacitate the healthcare providers on surgical intervention, and is through use of professional association, we have conducted the clinical attachment. To those new CMOC sites, we attached them to the regional hospital to make sure that they are capacitated, the surgical team is capacitated to be able to do the surgical intervention, but also to do an intensive mentorship to make sure that the healthcare providers are aware or they know how to do cesarean section. But also we have been leveraged the effort of Mama Samia campaign. When we know maybe the campaign at certain district hospital, we use that opportunity to bring the healthcare providers from other facility to that facility so that they can able to be capacitated very well. We also looked at the onset of complication, that is first delay model.
Summarize, Dr. Golison. Can you summarize, please?
Okay, thank you. Where we observed that some client started the complication at the community, And that the problem is not to start the complication. The problem is the condition the pregnant women come in at the facility, somewhere at the critical condition. On issue of timing of admission, we observed that the majority of admission occurred after day shift, which means from 15:30, where the healthcare providers at that facility are minimal compared to the morning shift. So what we support, we advised is equal distribution of healthcare providers at the facility. But also we observed from Friday to weekends, majority of the admission occurred in those days. So for us to be able to reduce maternal death, we have to make sure that the equal distribution of healthcare providers. Issue of referrals, also we observed some gaps where there is no communication between the lower level facility and high level facilities, but also the mode of transportation doesn't allow the proper management of care to be continued during the transportation. We observed, particularly in Dar es Salaam, majority of deaths were referral cases. 60% of conscious patients which were referred to Muhimbili, only 45% reached the conscious. Some reached the well semi-conscious or unconscious. What we supported is to work with the mama to make sure that we improve the referral system, particularly equipping the ambulances to make sure that they provide the adequate care, but also to continue use the WhatsApp groups for continuous care for pre-referral management. Also, we looked at the underlying cause of maternal death, where we observed the majority were PPH and eclampsia, and what we work well with the government to make sure that the emotive bundle, which is as observed to reduce the number of deaths due to PPH, is now incorporated in the guidelines.
Thank you, Dr. Godlisten Martin. Thank you very much. Big applause for Dr. Godlisten. Thank you very much. Asante sana. Thank you very much, the panelists, for that very nice presentation. Because I have said before that we are having another part of this presentation, that is to forge a way forward after hearing the presentation. Now, to give you an opportunity to participate in that second part, I'll give you, I'll take this opportunity to allow some questions. Anybody with a question, let me raise up your hands. 1, 2, 3, 4, 5, 6, 7 questions. So I'll give you this opportunity, but be very brief to the point, so that we save time. Kwa hiyo tutaanza pale 7 hands only. Or tutaanza hapa. I've marked you. No more hand. Nobody should be, stimulated to ask another question. Tuanze pale.
Yeah. Thank you very much for the great submission. I really appreciate. I have 2 areas that I really wish that you can speak more. One, what do we think if development partners pull off their support and implementing partners stop the complement effort that they are doing to the government? What will happen toward sustainability? And again, in terms of data, data collections and how we use our data, I like the way you have narrated the use of open data kits, the Kobo toolbox, and the other application for analysis. But what do we think about tapping from the existing nationally accepted mobile solution, like a unified community solution and AFIA SS, so that at least even if all effort goes off, we can still use the solution that has been accepted to the government to carry on the effort that you have started.
Thank you very much. And to whom does this question go to?
Okay, the first one is to Dr. Sande, but the second one is to Dr. Lipingu. Thank you.
It's only one question. There's no AB. Okay. Thank you. To the other.
Yes.
2?
Yeah, so
okay.
mine goes to Dr. Sande as well. Thank you for your elaboration. But as we have seen from the statistics, I've been attending MPDSR meeting for quite some years. And I feel so sorry each and every time, because from your statistic, it shows attitude and practice, almost like 69%. Despite of having all medical equipment, CMOC facilities, but when it's come to attitude and practice, and the question from the MPDSR form, which says, was this death avoidable or unavoidable?
And answer that.
You see?
Come to the question, please.
It does feel bad when it was avoidable. And now we see mushrooming of health colleges.
What is your
we
question?
We have new
please,
stuff.
Please.
My question is, what do we do to make these healthcare providers accountable, despite of having gynecologists coming into the MPDSR meeting in each quarter? We want to know, what do you do with these people? Accountability.
Thank you very much. Dr. Sande, that is for Dr. Sande. The gentleman there, please.
Thank you. Mine is just a question but a comment as well. My name is Gamariel Mboya from Aga Khan University. I am interested to know whether if the MPDSR system was taking into consideration understanding the maternal and perinatal death, if it was considering knowing how many people are people with disability, given the fact that people with disability have an added layer of impairment. And I want to know whether if the data you have collected can inform something in improving access to sexual and reproductive health services for people with disability. Thank you.
Thank you very much. Come to this side. Dr. Eric Yapa, alafu a lady behind.
Thank you very much, and thanks for the very clear and honest presentations. One question to Dr. Lupingo. In your root cause analysis, one of the behind the underlying factors, there may be, I want to ask you, the issue of affordability. Poor people cannot afford the complications to be paid for, as they are not free. And the increase of that amount of money has increased over time since the last 5 to 10 years. Is that in concurrence with your findings? Is affordability an issue? And if so, I think we should be honest and say so.
Thank you very much, Dr. Eric. Asante sana. Brief and clear.
Thank you very much to the panelists. My question will go direct to Dr. Sande, because moving forward, okay, I go by the name of Dr. Asda. Moving forward, you talked about the dysfunctions contributing to death is due to incompetency. So I have 3 questions. One, is it...
It's only one question.
Okay, I'll start them.
You can find him after the sessions.
Okay. Then I want to know, what level of incompetency are we talking about? Is it the midwiferys? Is it the doctors? And also, we heard about the trainings, on-job trainings that you are doing. How are we moving forward? How are we going to the problem of shifting of healthcare providers to other units? Because they try to train them, and the main problem is incompetency. Also, coming to the level, I'm sorry, please. Coming to the level of interns.
Please, no time. Please, there's other guest gentlemen.
Thank you.
We still have another exercise after this, so you can find the moderators after this session. They'll answer some more. Please give to the gentleman. Kai, and then the gentleman, and then we shall give the floor to the moderator.
Thank you.
The panelists.
Kaczor Pol of the GIZ, German Development Corporation. It's fantastic what you have portrayed. I'm really fascinated by all the results. So many questions. If I have to limit myself to one, then it's this.
Only one question.
We have fortunately also a number of facilities that do not report deaths. Nonetheless, next month they may have cases that need to be prepared for. So we have been working on near-miss cases and MPDSR for near-miss cases as a next step for those facilities. Is that something that you would also be considering as a recommendation for the standards in the country? Thank you.
The last question, and then we prepare for answer. I think most of the questions have gone to Dr. Sande and one to Dr. Lipingo, I think. Kariba, one question, not A, B, and C.
Yeah, good morning. My name is Machumani Kiwanga, registered medical practitioner from University of Dar es Salaam. Also, I'm a PhD candidate for medical tourism. I'm doing a SWOT analysis. Swali langu kwa researcher, kama umeweza kuwafikia wadau wengine katika kupunguza vifo vya mama na mtoto, hususani viongozi wa dini, wazee wa kimila and traditional practitioner. Tunafahamu wizara kwenye policy kuna swala alternative to medicine, na pia kuna emerging issue katika medical tourism tuna wagonjwa ambao tunatarajia kuwapata kutoka nje ya nchi yetu. Tumeweka mikakati gani ya kuwafuatilia huko walipo inapotokea vifo, wakati policy inaonyesha kwamba haturuhusiwi practitioner kuwasiliana kwa simu na wagonjwa wetu katika issue kama hizo za auditing? Nashukuru sana.
Asante sana. Dr. Sande, please. You can...
Wow, that was the response that we wanted. So on development and implementing partners, we have shown you the evidence that it works. The studies in the local context. So it's a call to everyone to come on board. As of now, we are getting a lot of support from USAID Afyangu and the other partners, but we wish to invite everyone on board to make sure that you take this forward. Asante sana. Attitude and the practice. There are a number of ways to address this. Of course, going back to our training colleges, pre-service training, it's where the point where you could take care of this. But post-training, there's an opportunity for value clarification and attitude transformation. So the means is exploring the options to have a guideline on value clarification that will be targeting not only post-abortion care, but also looking at other aspects of maternal and reproductive health care. Accountability. Accountability is a critical important subject in MPDCR. It's all about how much the issues account in terms of responding. People with disabilities, that's a very important point. Of course, we are now started a process to review our national MPDCR guideline. And we are taking that comment on board. We'll make sure that you have addressed it adequately, that element, so that we don't overlook in the past. Finally, from Dr. Asda, the question of competence. It's all across the board. All the cadres, midwives, doctors, you find issues. And this has taken us time to think through. In the pre-service, if the lecturers you are here, disclaimer, also a lecturer. Kama tuko hapa, kuna kazi kubwa ya kufanya kule vioni. So that we produce outputs. Kwa wale supervisor wa intern, kazi ipo kubwa. So that we produce good outputs. Finally, mwenyekiti, from Kai, near miss. The current guidelines requires to review near miss because they inform us more, so that we can do that. Even at a national level, we get opportunity to also review the near miss. Thank you very much.
Asante sana, Dr. Sande, Dr. Lipingu, and then Martin. Be very brief so that we can go to the second part of this.
Thank you, moderator, and thank you for the very nice questions. May I start with the use of tool? This is the question that we are receiving. Even the region, they want to use the same tool, so that data can go immediately to the regional level or to the national level. But the challenge is that tool is not only for data entry. There must be somebody critically analyze the case. Because some of the files that we received, you can see the cause of death is something else. For example, let me tell you one example. There were some cases that the patient went to theater and there was an anesthetic accident. But she went because of PPH, because of bleeding. The cause of death was bleeding. The second case went because of ruptured uterus. There was an anesthetic accident. In the file, they've written ruptured uterus. So that means you need somebody to critically analyze the case, not only data entry. The second question for the poor people, actually that is the delay model. If somebody is poor, can delay to reach the facility. So from the delay model, you can access that information. Thank you so much.
Asante sana. Dr. Godlisten,
okay, thank you
30 seconds, please.
Okay, thank you for the nice comment. Regarding the reaching the influential leaders, particularly the TBA, it is true we are reaching them through different intervention. We have the community scorecard where we reach different TBA and the other community leaders to discuss the issue of maternal death. But also we have in the MPDCR guideline, we have the issue area to discuss the maternal death which occurred at the community. Thank you.
Thank you very much, our panelists, for the very lively discussion. Please put your hand together for our panelists. And we thank you very much. You can go back, take your seat. Now let me take this opportunity to welcome Dr. Lusekelo Njonge for the second part of this session. Dr. Lusekelo is is experienced in programming and management of primary health care, clinical care and research and training. He successfully led to monitoring and evaluation in multi-year program around RAMCA that includes designing and implementing at national and subnational level. Dr. Njonge holds a Master of Science degree in health monitoring and evaluation with major focus on RAMCA programming. So please, Dr. Lusekelo, come forward to continue with the moderation of the next part of this session. Asanteni sana kwa kutusikiliza. Claps.
Thank you very much, Dr. Mzee, for having me. I would like to request the team to stand up because I want this session to be very much engaging. I would like everyone to stand, and I also would like to have Dr. Godlisten here, Dr. Joseph here, Dr. Lipingu, and Dr. Dominic. So the way I see the way we are sitting, I think already we have like 4 groups. So I would like to make that law as the first group. This is the second group. This is the third group. The other one at the back is the 4th group. So what the exercise that we are going to do here, we are going to develop a call to action. As you have heard, a lot of issues discussed pertaining to very preventable issue of maternal death. So what we are going to do here is to group based on the topic that I've highlighted. So we have heard the issue of human resource capacity and shortages. That I think the issue of accountability came up very strong. The issue of referral system also came up very strong. The issue of quality of care also came up very, very strong. So I would like maybe the first group, you develop like 1 minute, a call for action in that particular area. So this group, I think, will work on issue of HLH capacity and shortages, and Dr. Godlisten will lead that group. So you have like 10 minutes to develop a 1 minute call for action for the issue of HLH capacity and shortage. What do you want to advocate so that we can recommend? I think the exercise is very clear, yeah? So for this group, the issue of accountability, I think, also came up very strongly. Came up very strongly. So Dr. Lipingu, you will help this group to come with one for 10 minutes, just work with this team to ensure we have a call for action. What do you want to recommend to have this end up preventable maternal death? And this group will discuss around referral system. I think the issue of referral system also came very, very strong. So Dr. Sande will come up with this 1 minute call for action. And I think from this group, we also need to select someone who will also come to present that call for action. And the last one is maybe at the back. At the back, Dr. Masenga, maybe this part. Maybe this part here. Maybe working with this team to discuss the issue of quality of care and come up with one call to action so that we can address that issue. Karibun, I think the exercise is very clear. Is the exercise clear? Okay, so you have 10 minutes to do that work, and we'll convene after 10 minutes, and you need also to select one person. I think you need to move together. You need to move together. I don't know the modality you use, but after 10 minutes, I think you will have a leader here who will present your call to action. Karibuni sana.
Waambie muda, maana muda unakula muda wako mwingi.
Sawa.
Summarize hapa. Nadhani tatosha. Kwa sababu chase exactly saa 4:30.
Hello, I think you need to go to wind up to need to you needed to start winding up your discussion.
So like we don't have another one starting, so give them like 5 minutes if they're doing very well, and I would give them a 2-minute warning. In 10:18, give them a 2-minute warning, and then at 10:20, get them up there, and then if they're 1 minute, they should go, and then the manual will close. You did a really good job. Look at all this.
Umeongea na nani anasema advantage tulionayo hamna matumizi, yani watu wanaenda cheap rate. Watu wanaenda cheap rate. Kwa hiyo nani amesema dakika 10 na dakika 17, alafu watu waende cheap break wote wakapata chai hapo hapo. Sasa ni discussion ni nani? Discussion watu wangependa sana We have 2 minutes. We have 2 minutes to wind up. We have 2 minutes to wind up. Picha kuza sura bana. I think
so at 10:20, 10:20 you call them up, and then just give them 1 minute, and then
And you did such a good job tying MPDSR into root cause. It was really nice.
So that's
super clear. Your slides were great because they were just very high level. It was really, to be honest, it was one of the best panels I've been to this whole week. It was really clear and concise and just,
Thank you. Okay, thank you very much, team. Thank you very much, team. I would like now to maybe we convene again to finalize this session. And I would like to call the one whom we have selected to be to deliver your call to action to come forward. Later, wind up. Okay, let's wind up. Time is not on our side. Team, let us convene. Thank you very much. Thank you very much. Thank you very much. Okay. Thank you very much. I will call those who have been selected to deliver. Yes. Yes, yes. Yes, 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 yes. We're quality of care. So we have a member from the quality of care. So for the accountability. HLH capacity. Team, let's wind up. Dr. Lipingu. So good listen. Okay, thank you very much, colleague. This session has been very engaging, and I would like to congratulate everyone for really contributing to this endeavor. Now, because of the interest of the time, we have 4 colleagues here. They will introduce themselves, and they will introduce themselves. They will say which group they were, thematic area you have been discussing, and you deliver your call to action based on what you have discussed. So, without further ado, because of the interest of time, I will call upon my colleague here, Dr. Katanta Simwanza, to just say your thematic area and the call to action that you have been discussed. Karibu Daktari.
Asante sana. So my name is Dr. Katanta Mantamba, as my colleague have mentioned. I'm working with MDH. So we are working on the first questions, which was about HR and shortage. So the call for actions, as we discussed, one of the area we thought is very important is capacity building, especially in strengthening and coaching on areas around surgical skills, building skills labs, which will provide spaces for transforming skills of service providers, ensuring the IPC trainings are provided very well, but also conducting outreach services, and also pre-service education to be used as one of the area to be, So for the shortage of staff, the proposed area is to make sure that we employ more service providers, but also the public-private partnership to invest more on that area, especially by engaging the communities. For example, working with faith-based organizations to train community health workers, but also basically that was suggested.
Thank you very much. I think we'll have a time to clap for this colleague, but a big hand to the HLH capacity and shortage group. Karibu. You can introduce your group and Karibu.
Okay, I go by the name of Dr. Asda Kwariko. I also work with MDH, and our point was referral systems improvement. So our call for action is basically because we are moving to universal health coverage, and also we are Bima ya Afya kwa Wote. We thought that if the insurance system is improved, that it will include the package for referral systems. Whereas at every point, from the community to the hospitals to the ambulances, as we know, we have the app currently. So if the insurance financial system is well strengthened, I think we can be able to tackle this problem of referral system problems.
Okay.
Thank you.
Okay, big clap for our colleague here. So because of the interest of time, let's go to the other group. We'll clap for them at the end of the session. Karibu, Doctor.
Okay, I'm Dr. Christina Sanga, a medical graduate from the University of Dodoma. I'll be representing the second group, which was having a discussion on leadership and accountability. So we had suggestions. First, on the leaders have to make a proper distribution of staff in all shifts, as we saw from the report that many of the deaths were occurring at the times where the staffs are few. So there should be proper distribution of staff members so that the work should be done based on the workload. The other suggestion we had was on capacity building among the staff, with either having mentorship, and also we had a point on proper and cross supervision on the new staff, intern and students, which are also enrolled in provision of health services. Also, we had the use of available data we have seen and we have on decision making, whereby we'll have to make decisions first from the facility before sending them to the regional level and the national level. And also motivation services to the staff, so that they should be increasing, they should be working more based on the motivation which they'll be given, like in extra duties when they need transport, and they can also be accommodation services based on their shifts and also the use of friendly and educative services, of which this has to be done maybe in the morning meetings. If something happened, they should communicate, we understand what is the cause, and later we should take action friendly and not too much judgmental, so that we should solve the problems. And the last one is proper communication and interaction among the services.
Asante sana daktari. 1 minute. That is the last one.
My name is Rita Mbeba. I'll just go quickly to the recommendation from the quality team, quality of care. So one of it was because the percentages of the cesarean section was shown to be 50%, what we proposed was to set initiatives of reducing unnecessary cesarean section. Also labor monitoring should be well improved. Check health providers versus client ratio at labor wards. And also the need to strengthen teamwork and shared decision making. And also integrate pre-pregnant and pregnant nutrition, reward and motivate providers, instill the culture of no name, no shame, no blame, and staff retention in maternity unit. Thank you.
Asante daktari. 1 minute, Dale.
Yes, you've already mentioned me, I'm Dale. So I'll represent group number 2. We highlighted some have already been mentioned. We have accountability. We need to hold them, every party accountable, from individual level to the professional association level. They also need to be accountable. But also, in a session like this, so it's where the issue of pre-service was also mentioned. So we need to engage tutors, lecturers. In a forum like this, they also need to be here so that they can see and learn about these things which are happening, because they are the ones producing these healthcare workers. But we also need to enforce the adherence of the guidelines. We've noted that the deaths occur, many deaths, a specific range of time, and mostly due to the weekend. So the service guidelines needs also to be enforced. But motivation has been mentioned, but also NPDCR needs to be done timely. That's another challenge. We're also seeing that.
Okay. Naomba tusimame. So a big clap to my colleague here, and thank you very much, team, for a very engaging session. And I think we also need to share what you have developed so that we can consolidate and have summarized to this call to action. Thank you very much, team, and thank you very much. Now, Dr. Mzee, this is your session. Dr. Mzee. Okay.
Thank you very much. We can give a round of applause. More than that, you can do more than that. Thank you for our moderators and all the panelists.
Okay, so Dr. Mzee, you will need to welcome Dr. for the closing remark. Dr. Tula.
Thank you very much for a very lively session. So I'll welcome Dr. Tulai for a closure, and thank you very much for participation. Asante.
Asante sana. Thank you very much, Dr. Mzee, our moderator, for a very great session. So good morning, everyone. My task is really small, is to say this session is officially closed. But before that, let us acknowledge Ministry of Health through the Division of Reproductive, Maternal and Child Health for leading the efforts to address maternal and perinatal death. They are really doing a great job. We all know the reduction our panelists talked about, the 30-something% of reduction as far as maternal and perinatal death are concerned. So join our hands to clap for. Yes, that's one. Number two, to our organizers, USAID Afya Yangu Mama na Mtoto, for organizing such a very, very good and informative session, and for all of us to participate in this session. Join hands again to everyone. To our panelists, moderators, keynote speakers, colleagues that have just mentioned or rather talked about next steps and actions moving forward. We really congratulate you. You have made my work really easy because everything is already said. We know the root causes, we know what are the actions moving forward. So one thing I can say, one word that nearly everyone was talking about is mainly accountability. Accountability is really key if at all we wish to meet SDG goals coming 2030. So let us do our part. Let's be very responsible to make sure that we achieve as a country. Also, one of the panelists talked about maternal causes, complex and multifactorial. I think it was you, Dr. Sunday. So that call for multi-sectoral engagement to make sure that we all address the root causes of maternal mortality. So this is the call for everyone in the room, everyone you know outside the room, to join hands with government of Tanzania to make sure that we address these well-known already maternal causes. From a USAID perspective, we'll continue to do our part to complement government efforts. For sure, coming 2030, it is very possible to meet the target. So after all those not so short, not so long remarks, it's now tempting to say this meeting is officially closed, but how can we close such an important topic? So the session is postponed. Please continue to discuss, and we'll reconvene again similar meetings to make sure that we meet our SDG target. Asanteni sana. Thank you very much.
Thank you. And as before we leave, on behalf of Tanzania Health Summit, I would like to request also Dr. Emmanuel to wait here. Tanzania Health Summit, we recognize your contribution through this forum. So we have a trophy and recognition which will be given by Dr. David Isaiah to Dr. Emmanuel Tulwe on behalf of the USAID. So you can give a round of applause as they receive it. You can do more than that. Clap your hands as thank you very much. So we have reached the end of our forum, and now we are heading to the Okay. We shall have a group photo for panelists, but also after this we shall be having a tea break. And we shall have a next session at 11 a.m. in this room. Will be held by Inakofa. So welcome the panel and the moderator for the group photo.